Futures platform and share it for people that can't make it today. So welcome to everybody today. It's really nice to see you all. What we'll do is the session's divided up a little bit today because we've got Amy Cook, who's a physiotherapist from Bath, North East and Somerset, I believe, who's going to talk to us about the seated exercise project. And then we'll introduce Dr. Imogen Staveley, who I think it's your first time at this meeting, isn't it, Imogen? Fab, who's going to talk to us about tackling harms together, which is actually a real theme at the moment, you know, kind of nationally and also on the WhatsApp group for Reconditioning the Nation. And then we will have a kind of a national update from Dr. Amit Arora, who's also on the call. So I've seen that you've joined, Amy. There you are. So do you want me to hand over oh, I'm transcribing actually. No, I don't want to transcribe the meeting. What I'll do, Amy, if I hand over to you and I will stop transcribing and just record the meeting because that's going to drive everybody mad in the chat. Any questions or anything for Amy? Amy, would you prefer people to put their hands up and ask you or wait to the end of when you've been chatting?
If it's okay, we'll wait until the end and then I'll try and go through them all as a Q&A.
That's perfect. Over to you then, Amy, and I will sort out the recording and transcribing.
Share my screen. Can you see that?
We can indeed, yeah.
Brilliant. Okay, so my name's Amy. I'm a physiotherapist and I work across 2 community hospitals. So one in Poulton and one in Bath. And we are mainly an elderly rehabilitation inpatient unit. We have 28 beds at one and 29 beds at the other. And this is around the QB project, which we started back in August of 2023 as a way to try and increase the amount of exercise going on. We often found that patients were sat in their chair all day, not really doing much, sort of, they would have their therapy and then they would sit back down until the next therapy session. So really this was a way of trying to increase the amount of exercise, and we've finally kind of finished our project now, so we have all of the results, which I'm going to share with you. So the aims of the project were to increase the amount of physical activity, to engage more patients in strength training, and also this was to prevent hospital-acquired deconditioning. So we did take part in Recondition the Nation. So this was kind of to keep the momentum going and what else could we trial. So we were kind of inspired by the campaign, and this is sort of our work as a result. And you can see there 2 of our patients having a go on them, and we often found that setting patients up on the machines next to each other created a bit of competition and provided a bit of a motivation as they were trying to beat each other.
Hello.
Hello.
All right.
Hi, if you're not talking, can you go on to silent, please? Thank you.
So, as I said, we started in August 2023. So we started off with 1 ward and then the 2nd ward joined in September. And that was just to try and sort of phase the project in because I was leading it. I couldn't be at both sites at one time, and also to trial how it went for the first month to see whether it was worth rolling out to the 2nd ward. So we purchased 6 of these QB machines. And these were funded through a grant. So I work for HCRG Care Group, which does provide NHS services. So they set aside, I think it's £100,000 a year, that they call it the difference grant. So if you've got an idea that you can make a difference, then you can access this money, apply for the money, and you have to run sort of a pilot project and then feed back on how it went at the end. So back in August, we created some patient eligibility criteria. So we wanted a really simple way of deciding which patients could use these exercise machines and which patients they weren't appropriate for. And we wanted this to be as accessible for as many patients as possible. So you can see they need to be able to sit in a chair. So these are seated machines, not for standing, and they're not adaptable for any bed exercise. They need to be able to fully weight bear through both legs. So that came about just sometimes we have patients partially weight bearing or non-weight bearing, and although they're sat down, we can't actually measure how much force they're pushing through that leg. So just as a blanket rule, and to try and keep it really simple, we've said only patients that are fully weight bearing. Obviously consenting to exercise, so agreeing to use the machines, and also can follow simple instructions so that they are going to remain seated, and they are going to push the pedals round for that session. For those with cognitive impairments, which we do have quite a lot of on the ward, it doesn't mean that they're excluded. We just had to be really careful with the timing of the sessions. So we have some ward volunteers. So if we know that they're coming in, say 10 o'clock, then we would set a patient up with them at 10 and they would sit and supervise. Same idea with sort of visitors or family members. And if people don't have many visitors, then therapists were sitting with them. So it might be towards the end of the day where we've got lots of notes to catch up on. So we would sit and write our notes in the bay, so we can keep an eye and supervise on those that might be at risk of standing up and falling over the machine or something. So it was adaptable for those with cognitive impairments. So the outcome measures that we used for the project. So we've used 5 at the beginning. So our initial collection was for 3 months, and then we've continued with these other 3. So show you them all. So we collect how many different people use the machines monthly. So we want to know whether it's just one person cycling for hours, or is it widespread? Is it quite a few patients using them? How many minutes of exercise is completed each month? And we keep a tally. It's all on a spreadsheet, and I send out the scores. So we have a bit of a competition between staff. The elderly mobility score. So this was one of the ones we did as part of our first 3 months. So I've got a separate slide on that in a minute, where I'll go into detail. And the 5-minute test is the other one that we only did as part of the initial 3 months. And I've also got a separate slide. And then the feedback. So we've collected feedback throughout, and we still collect feedback via questionnaires. And we did patient feedback as well as staff feedback, so we can get everybody's views. So for the first 3 months, we had 143 patients use the machines. And of those patients, 86 of them completed the 5-minute test. So this was on their first go during the beginning of their admission. They would cycle for 5 minutes, and then we would record the distance that they cycled. And then they would use it throughout their admission, hopefully increasing the resistance level. And then on discharge, we would repeat the test, so 5 minutes again on level 1, and we would compare the 2 scores to see if we were making a difference. So this is what we found. So in those 86 patients, 71% of them increased their scores. So actually cycled further within those 5 minutes. 11.6 stayed the same, and then the 17.4, they got worse. But it's important to note that the differences were quite minor. So those that decreased, 2 of those patients were by 7 strides, so 7 rotations. Another one was 12. So really not that significant, but a decrease nonetheless. And then we collect our monthly data. So you can see in August, that was just one ward doing it. And we had almost 2,000 minutes of exercise cycled collectively with all of the patients. Even better in September when the second ward joined, decrease in October, and then back up in November. So we were seeing some serious hours of exercise going on just by using these machines. So the elderly mobility scale. So for those that don't know, it's an outcome measure used in elderly adults and it's scored from 0 to 20, and it looks at lying to sitting on the edge of the bed, getting back into bed, sit to stand, can they stand without holding on to anything, can they reach, are they mobile? So we record this anyway as part of our initial therapy assessment, so it wasn't anything additional that we had to do. So we look at it on admission, and then we repeat it just before they are discharged, and then those scores do get recorded on their discharge summary. So we are really making sure that we did record them. And to sort of make it fair, we wanted to compare August to October the previous year without the QB machines compared to August and October with the QB machines on the ward. So this is what we found. So 67 patients were included in the 2022 data collection, and we found our average admission score was 6 out of 20, and then on average their discharge score would be 10 out of 20, so showing a change of 4 points on this scale. And then in 2023 there were 64 patients included, so 3 less than 2022, and you can see the admission score interestingly stayed the same at 6 out of 20, but the discharge score did go up to 10.5, so we've got a change of 4.5, so 0.5 more than the year before. Whether that was related just to the QBs is really difficult to say. We obviously tried to keep most things the same. In 2022 we were doing Recondition the Nation a little bit and trying other sort of exercise ways to engage people in exercise. So it's difficult to say whether that's purely down to the QBs, but it's good to see that we have made a little bit of a difference on that scale. Patient feedback then, so we still collect patient feedback now, so that's a screenshot of question 1 and question 2 on the questionnaires. So we've had 79 questionnaires completed so far. So question 1 is to rate it, how much did you enjoy using them, from 1 to 10, and on average people were scoring 8 out of 10. And then question 2 was the reasons for their score, so we've had 79 comments, so I couldn't include all 79, but I've just picked out a few. So I really enjoyed it, very good for your legs, it feels as if you're doing something worthwhile, and that was really important, that patients actually felt like they were exercising and achieving something compared to just sitting in the chair all day. And you know, hopefully it would do my muscles some good. They've been happy using the machine. I'm pleased to have treatment so I can get back on my feet. So patients really do see these machines as part of their therapy, and it's a really positive thing on the wards. And then question 3 and 4, so it was only a 4-question questionnaire to make it really simple. So it was an agree, disagree or unsure statement, and they just had to tick the box. So it said, having the machines in hospital is beneficial for patients, and you can see 96.2% of patients agreed, and actually the same number agreed that they would use them again if they were readmitted to hospital. So that kind of shows the patient feedback. They are really liked, and we have lots of patients using them every day on the wards. And then staff feedback. So this was anonymous. It was sent via an email link, and I couldn't tell who had filled it in and what they'd said, as a way to get some really honest feedback. So for me, the comment that says it's quick and easy to use, it absolutely is. It takes probably a minute to get consent and put the machine in front of the patient, and then about again a minute to take it away, give it a quick wipe and document in their notes. And we had exercise stickers, so you had to fill in 3 numbers and then stick it in their notes, so it's so easy to document. And it's great that the machines can be used by therapy and nursing staff, so that's kind of where we're at now with the project, is rolling it out to the wider MDT and who else can be using these machines with patients. Lots more comments. So a wide variety of patients, which is absolutely true. The majority of our patients fit that eligibility criteria and can use the machines. And because it's so quick to set somebody up and then to take it away again, despite our staffing levels, we haven't increased, we haven't put an extra therapist on to do this. We've managed to create so many minutes of exercise each month, regardless of what our staffing looks like, which I think is really important for us as we're quite a small team. And then more recently, so this was December 2023 up until March 2024. So our numbers have increased. The project is growing. More staff members are being involved. It's definitely embedded a bit more. So you can see we were sort of around 2,000 when it first began, and now we're double it some months with over 4,000 minutes of exercise. So I think that's a really positive finding. And our record month, there was 4,310 minutes of exercise across 41 different patients. So that's over 71 hours. And again, the therapists haven't really done anything differently. We've spent a couple of minutes for each patient to pull it in front of them and to document it. But we've not added any extra therapists. So the next steps, so we definitely want to carry on with our training of healthcare assistants and nurses. So they're here 24 hours a day and on weekends. And the Saturday service we provide is one therapist for 4 hours. So you often can't get around to everybody. 28 beds with one therapist isn't going to happen. So what we found is if we can get other staff members to be on board, then they can set people up, especially on Sundays. There's no therapy at all, or evenings. And even on a Saturday service when it's just you working, it's meant that we can put on 6-7 patients for every Saturday, and they do, I don't know, some people do 10 minutes, some people do up to an hour. So it means that those patients are getting that strength exercise with the same Saturday service that we've run. So our next steps are definitely to keep doing our data collection. I'll keep sending out the monthly totals to the teams. We have a staff leaderboard going now, so we can see who tops the leaderboard for the most amount of patients put on. And I mean, one physio assistant who works 3 days a week put on 47 patients in a month. So the staff are really on board with it, and as a team, we're really achieving great numbers. My plan is to share it widely, so this is part of that, but also to talk about it on social media, the company conference that I'm going to be presenting at. So we just want to get it out there that we found something that works really well and we've had really good feedback. So perhaps other teams can be inspired and do something similar for their patients. So my top tips would be to start small and scale up. So just doing one ward to begin with is how we started small, and then we added that second ward. Engage the team. So like I said, the team are really important. I personally haven't achieved 41 hours of exercise for those patients each month. So getting the team to be using them as part of their therapy and as part of their even the nursing staff using them as part of their treatment is really important, and keep spreading the word. So like I said, I'm going to be talking at other conferences, regular talks with managers, just to try and keep pushing this project and showing that we're doing something quite simple but actually is really effective. And then that's it. So I'm happy for any questions. I'll stop sharing my screen and I can see you all.
Wow, thank you very much, Amy. That's incredible. And doesn't it go to show the value of getting patient feedback as well and auditing, actually not just doing something, but actually really looking at the value that adds to our patients. And actually in terms of exercising hours, that's fantastic. Really, really well done. And it's fantastic that you can come here and share that, because that's what I've, is so good about this network. It's very informal and we can share good practice and inspire others. So there's a couple of hands up. So if I go to, is it Madar? You've got your hand up?
It's Ham, it's myself. Hi. Amy, I thought that was brilliant. So I work with care of elderly and frailty at South Warwickshire. I'm the service manager there. I think that's really nice, something that we would like to get on board with here as well. I just wanted to check, are they anti-slip machines or do you have to use mats underneath them?
Yeah, so the feet of them have like the grips on the bottom. We found that over time, because we're using them so much, one of the machines has actually started to lose its grip. But on the QB website, the UK version, you can get free anti-slip mats. So for that one machine, we've got the mat now that goes on the floor and then the QB on top. So we've kind of problem solved, and it's not been an issue at all.
And how much are they? How much is one machine?
So we got them at £109, I think. They're currently on Argos for £130 when I looked the other day for somebody. We're finding our patients are going away and buying them. We did ask if we could have like a rep code or, you know, get commission or something, but a discount code for the patients, but the company weren't keen. But yeah, so they are affordable. And, you know, just a couple of machines on the ward, you would see benefits.
Thank you, that's great.
Great, thank you. Any other questions? I think it's really good, Amy, that you actually looked at the getting a grant to try and, you know, £109 is not a lot, is it? If we think about the long-term effects of somebody remaining, you know, and deconditioning whilst in hospital. Oh, so Kate's now got her hand up, so we're bringing Kate. Nice to see you, Kate. Although your camera's probably not working, we can't see you, but if you can speak.
Hello, can you hear me? Sorry, my camera's a bit broken.
Yeah, we
I
can
was
hear you.
just, Amy, this is amazing work. I'm thinking about storage and I'm thinking about any kind of datexes that you had. Did you have any extra risks associated with using the machines? I know in your presentation you said that you didn't, so of your 5 metrics, you didn't collect any data on that. But did you have any falls of staff tripping over the machine or patients tripping over the machine? I'm just thinking because I've seen these machines in practice and sometimes because they're quite low to the ground, if you've got somebody who's a bit visually impaired, sometimes it can be quite difficult for them to navigate. And I was thinking about storage. Did you have any problems storing the machines? So really boring questions, sorry.
That's okay. So we've got some trolleys. I should have put a picture, but it's a 2-tier trolley. So one's on the top and one's on the bottom. And we store them at the moment either in the gym overnight or in the day room overnight. And then during the day, they're sort of just tucked inside of bays or in the corridor, or they're in use. In terms of like tripping over and stuff, touch wood, nothing's happened in terms of like a datex. Those patients that might get up and, you know, potentially fall over, we wouldn't have left. We would have made sure somebody's supervised. So yeah, I think we've been quite careful in the choosing the right patients to leave with them. And as part of that 5-minute initial test, we stayed with them for the 5 minutes so we could see how they got on, if they wanted to stop, if they were going to get up. And then once we sort of deemed them as safe to use without us supervising, they got a sort of sticker on their cupboard, their wardrobe, and it says like, please help me use it regularly as part of my rehab. So then nursing staff and therapy assistants can easily see which patients they can use it and be left with the QB machines.
That's awesome, thank you.
Thank you, Amy. Just before we move on, VJ's put a question in the chat. How did you manage to balance the EMS ceiling effect?
So we, like I said, we collected the EMS anyway. A lot of our patients don't get 20 out of 20. You see our average discharge score was 10. So I think that was probably an appropriate measure for our patient caseload, but perhaps if you were doing it in a different environment and your caseload was slightly different, you might have to look at a different outcome measure. But yeah, we certainly didn't hit that ceiling at all with most of our patients.
Great, thank you. Kate, your hand's still up. Did you have a new question or is that a legacy hand?
Apologies, it's the legacy hands, I'll pop it down.
No worries. Okay, thank you. Thank you, Amy. That was really interesting, and we would definitely want to help share the great work that you're doing kind of nationally and through our network, etc. So let us know when you post it on X, and we will help share that and get the word out there. So thank you. Okay, so next we'll move on to Dr. Imogen Staveley, who I'll let you introduce yourself, Imogen, and what you're here to talk about today.
Thanks, Zoe. Can I just quickly ask how long I've got, just roughly, so I pitch it?
About 10, 15 minutes, but
Thanks,
we can be really quite flexible.
That's really helpful, Zoe. Thank you. So, hi everybody. I'm Imogen Staveley. I'm a GP by background, and I'm currently the Chief Medical Officer in Northamptonshire ICB. I've been seconded out from NHS England, where I've been working for 2 years, and in that time, I've become really passionate about tackling harm together. Now, trying to explain what that is. I believe that if we can get clinicians really understanding the harms caused by poor UEC flow, and getting them working alongside their ops colleagues, management, and working in a really truly multidisciplinary way, we can sort of improve and reduce the harms that are coming to patients. So it's across the whole journey, from the patient waiting for an ambulance at home that hasn't got any clinical care yet, all the way through to somebody, for example, having a really long wait in A&E, through to somebody waiting for longer than they would like for a discharge for whatever reason. So this started from the 100-day discharge challenge, and one of the points in there was around how to measure the harms caused by delays to discharge. But we just felt you can't just look at the discharge end. It really does impact all the way through the patient journey. So we wanted to think of different and creative ways to get clinicians on board. So Recondition the Nation is a fabulous sort of part of that. And what this community of practice is aiming to do is draw together all the bits of examples to sort of share good practice, do a bit of myth busting. So something that I really liked in Amy's presentation was about how do we then get staff outside of therapies to do the to encourage that level of exercise. So things like myths that I've heard on things like MAID events that I've done in trusts is, oh, only physios can mobilise the patients, the nurses kind of can't, you know, which I'm not saying that is everywhere, but that does happen, sort of bits of myths like that. So it's around myth busting, it's around also trying to get support from all of the MDT. So for example, with criteria-led discharge, which is a really effective mechanism, at times, and I feel like I can say this as a doctor, the doctors maybe don't always get it as well as the nurses do and make it really clear what those criteria might be. And also they might feel it's limited to certain things like a day case surgery, whereas we know there's evidence that it can work in a broader way. And it's all it is with doctors is getting them, they write really good plans, but actually it's getting them to translate those plans into, if you're wanting a CT scan, and the so what, if it shows X, what happens next? If it shows Y, what happens next? And things like having on admission clinical criteria for discharge. So I always describe it a little bit like your car going to the mechanic. Usually your car going to the mechanic, you are really clear what needs to be done. It's the tyres need checking or something, or the steering wheel's fallen off, and that's going to be fixed, and then you get the car back. Patients going into hospital, unfortunately, particularly the frail and elderly, there can be a bit of scope creep. They might go off in because they've had a fall, but then while they're in, they notice a rash and they do an internal referral to derm, and then something else happens and something else. And I think at times there's a bit of a risk averseness to send them home to the community for that to happen. There's loads of reasons behind that, like people not always understanding what can happen in the community, people kind of wanting to do a really, really good job, which actually sometimes hinders the kind of bigger picture view of what about the other patients waiting. So it's a really complex topic. Lots of people much brighter and cleverer than me have been trying to do this work for a long time. But what I'm hoping to do is bring people together, create energy. And why I wanted to come and see you guys today is just spreading that word further. If you've got any colleagues that you think might want to join the community of practice, we've got a WhatsApp group, we've got monthly meetings where we sort of share good practice, and we've got a heap of resources. What I wanted to do was share a little bit of the resources so you know what is available. So if I may, I'm going to try and be technical and share the video that we first created that we think of as a conversation starter in this space. So bear with me 2 seconds, because I know I need to hit include sound. Can you see a YouTube page?
We can, yeah.
Right, I'm going to go for it.
Video has been created by doctors, nurses and therapy staff with a passion for reducing the harms caused by poor patient flow. We want to share stories, evidence and resources to give colleagues food for thought on this issue. Resources will be embedded in links beneath the video.
We do understand the huge challenges of working in the NHS at the moment, yet we still believe small changes in our actions can make a huge difference to our patients.
Sarah was admitted to the ward 10 days ago. She's deconditioning due to spending so much time in bed. What really matters to her is her dog and her grandchildren, and she wants to get back to them. She's worried she may not be able to walk her dog when she gets home, as she is feeling weaker. Although a consultant sees her daily after the board round, and she is well known to the nurses and physiotherapists, Sarah is still not sure of the exact plan to get her home. Her family keep telling her hospital is the safest place for her, but is it?
This could be any of our parents, grandparents, or relatives. Small changes to improve Sarah's journey through the hospital could have an incredible impact on her and might make the difference between her going home independently or dependent on others.
Nurses, doctors and therapists like us tend to focus on the patients directly in our care. However, it is important to realise that our actions have an indirect impact on many other patients too.
By ensuring patients like Sarah have a clear plan for discharge, they are likely to leave hospital in a safe and timely way. This in turn can have a positive impact on several other patients and the doctors, nurses and therapists taking care of them.
For example, Layla, a child with cerebral palsy and a learning disability, is waiting for admission to the paediatric ward for her chest infection. She is frightened by the emergency department's environment. The nurses looking after her are doing their best to make things better for her, but it feels impossible as the department is so overcrowded. When Layla transfers to the ward for the specialist care she desperately needs, they are able to move on to supporting the next child in need.
And Zach, who has a sudden cardiac arrest in the community when out with his friends. The paramedics are able to swiftly hand over their last patient to the emergency department and rapidly get to Zach in time to save his life.
We all want to do the best for our patients, but sometimes things get in the way of this. Within our available resources, is there anything we or our teams could do slightly different to improve the patient's journey through our hospital?
We believe that there are small steps that we can take individually and together as multidisciplinary teams to make a difference, and have gathered resources together to support those wanting to try something new.
We are also working hard to influence system and hospital trust leaders to support you in changes you want to make.
The regulators are behind this too. For example, the Care Quality Commission recently published a document called People First that is behind system leaders wanting to reduce the harm in the UEC pathway.
Thank you for all you have been doing and will do in the future to ensure safe, good quality care for all our patients. So I'm just going to quickly show you our future.
Ever noticed how some people don't seem to age?
I'm in shock. For anyone who hasn't heard about this new 60-second and
Sorry.
You're right.
Best laid plans. Just wanted to share the resources that we're talking about. So we have got a futures page, and we have things like a poster that can go up on wards. It's NHS endorsed. We've got, for those clinicians who really like evidence-based, we've collected all the evidence around the harms and put it in a sort of infographic, but also for those that want to know which papers, etc., and more specifics, it's all there. We have also now got some podcasts which are aimed at different clinical groups, but then can be listened to by any clinical group. So those are all available. And then we have many more resources within, so stuff around Safer Bundle, trying to things that exist already, but bringing it all together. I'm now going to stop sharing. I'll put the links to that page in the chat shortly. I wanted to just share sort of some tangible things that have come out of this community of practice, because it always helps to know what this really means. So I would share that there's an incredible matron called Zoe Pearce who works in Barnsley that many of you may have met before. She has worked really closely with me on this and has sort of really spearheaded what goes on in this space. So she's looking at things like mandatory training that happens around manual handling. Often the information that you're given is about lifting, for example, a box, and it's not actually very patient helpful. So she's trying to, for example, make manual handling training that is mandatory more useful in terms of all people understanding how you might safely maneuver a patient around so that they could mobilize. So rather than creating some sort of new training, which she's been aware of pitfalls of that, because with CQC coming around at any moment, you're always scared of introducing a new training, because then you'd have 0% compliance because people hadn't done it yet. So she's sort of looking at maneuvering the training that already exists She has also been looking at how to sort of measure deconditioning through the patient journey, and that's linked up with Amit's hospital, and I know Nottingham as well are also looking at measuring deconditioning through the journey, and by sort of this community of practice bringing people together, we kind of learn about how that's going and moving things forward. So I suppose I'm just looking also for suggestions. Anyone think we could be doing anything different? Always willing to get feedback on that, but also just to open invite, warm invite to anybody that is interested in that side of it. It is very complementary to Recondition the Nation, and there's elements that fit into both, but it is around that real culture change of getting our clinicians on board with the harms of poor flow and what can they do differently. And so hope that's a good intro, but please do ask any questions.
Thank you so much, Imogen, and I think everything you said before you showed the video really resonated with myself, and I'm sure other people on the call. And I think that that's what this Ambassadors Network Forum is really good at, sharing that good practice, because what I've definitely realised over the last 18 months is the huge amount of really good work that's going on individually in pockets of organisations, and actually it's about sharing that and complementing that to benefit our patients at the end of the day. Otherwise, what's the point? So I know there'll be some people in the chat and some people putting their hand up. So I will, Kate, you've got your hand up, so I'll bring you in.
Hiya, my name's Kate Hanson. I'm a specialist sister in ICU rehabilitation down in the Southwest. Lovely to meet you, Imogen, and great presentation. My feedback would be, I think having a patient narrative with real patient stories, I think would really add weight to it, because when we've done some engagement work previously with rehabilitation in my region, we know that when we share a patient story with a very clear visual narrative, it acts as a really key intrinsic motivator for clinical staff. And I think sometimes if we produce, in inverted commas, generic videos, it can turn people off within the first 10 seconds. So I think it's that thing about weaving through a really clear patient narrative regarding patient benefit of early rehabilitation and rehabilitation both in hospital and in the community, and how that can be self-motivated and actually led by loved ones too. I think that's a really important narrative, but I think sometimes having a patient story is a really good way to engage and build relationships with staff, because I think some of the challenges we have, as you've said, is lots of staff are feeling quite clinically overworked and burnt out. And if we can flip that narrative of this is something that you're doing not because you're being told to do, but because you know this is absolutely the right thing, and the best way to convince people it's the right thing to do is to tell them the patient stories of the differences it makes. Just some feedback just for moving forward.
Hey, it's really helpful. So some of the stories within the video are true stories, and there was issues around getting consent, etc., to share the specifics of the details. But for example, the young gentleman that had a cardiac arrest sadly is based on a 19-year-old from Rugby who did die on New Year's Eve 2 years ago. And so I'm with you that I think true patient stories help. Where it's been most effective is when the video's been used with a really good leadership style around bringing in some local stories in trusts, and it's brought about really honest conversations. So an honest conversation that came out where it was led well was nurses being really honest about the fact sometimes doing a discharge they actively avoid doing because they know it will mean a new admission, and they're just knackered and they frankly just don't want to do it, and they think we'll just leave it to the next day. But by having a conversation about then the fact that they do see these patients then falling, and then they have to do lots of work around datixes, etc., and it creates work. And I think they had a bit of a eureka moment having the conversation that actually it recognizing the positivity and kind of agreeing to sign up to it all together, and also a bit of honesty about how some nurses might be more active in the discharge department than others, and trying to work on it collectively as a group did then lead to more action in that front. So I do think being really conscious, I agree where staff are at the minute and they're knackered, it's how they kind of get that eureka moment, and it's seen as a positive thing that actually gives them even a better sense of value in what they're doing. But it's hard, it's really hard.
Absolutely, it is. It's really, really hard. And I think it's about making sure that we can engage everyone within the clinical team to see that rehabilitation is everyone's responsibility, irrespective of the colour of your trousers. And I think sometimes that narrative can get lost when you've got, 30 patients, of which 20 need IVs, and you've got your 2 members of staff down. And it's about, you know, rehab isn't walking, rehab is functional rehab, brushing your teeth, brushing your hair, feeding yourself. You know, it's everything, isn't it? Rehabilitation is everything, function is everything on a ward. It's about renaming, relabeling that stuff and making it everyone's responsibility. We've had some success with sharing patient stories locally. And actually, I think sometimes we need to push through some of the bureaucracy that is, oh, we can't share that patient story, we can't share that patient video. If we can really show patients in their when they're at home, and their stories of positivity about rehab and getting home earlier, like you say, with their dog, whatever their hobby or goal of choice is, I think that has real power with clinical teams to elicit real clinical change. But I think we have to be bold and brave as clinical teams to share real patient stories with photos, with podcasts, with poems, whatever metric a patient gives us to be able to share it. I'm a massive advocate for patient stories, but thank you so much for your work.
No, that's really helpful. And I take it on board. I think the more real and more local this message is, the more effect it will have. And so, you know, take that on board.
Thank you very much, Kate. Any other questions at all for Imogen? I've got loads, but I'm very aware that we've got 20 minutes left. I think it would be really good potentially, Imogen, to we can share the links to the networks you were talking about, and actually we can perhaps see if Zoe is free to come and join this meeting one day, because I think that's what this forum is about, is sharing that good practice. So that's great. Thank you so much, and you're very welcome to attend this on a regular basis, because everything you've said is everything that we say you know, all of the time. So thank you very much for attending. So last but not least, definitely not least, I'll hand over to Dr. Arora, who's going to give us a national update and kind of current thoughts of where we are.
So thank you. And I think what I'll do is I'll actually carry on with the theme generated by Kate and Imogen. So thank you very much for that. And to continue on the theme of the stories, and I don't know, I've not kept this as a secret, and I think a lot of people know about this. How did my own interest in deconditioning started? So at the age of 30, I underwent an emergency appendectomy. And of course, the doctor said complete bed rest at the time, the surgeon, and I followed it to the minute. And I was completely bed rested for about 10 days. And then when I actually started to walk, I could hardly walk from my bedroom to the kitchen. And the day I remember very distinctly when I stepped outside of the house, and I just really could not walk for more than 10-15 steps after about 10 days. And I said, oh my God, what's happened to me? Anyway, so that slowly got better. But after about 2 weeks, I decided, okay, I've had enough of bed rest. I'm going back to work. And for the first week, I could walk on the ward. And then I think something happened, and I was although I shouldn't have, but I was told, well, can you help with this cardiac arrest bleep? Because we were short of doctors or whatever it was. And I know that I could barely run when the cardiac arrest actually happened on the ward. So it was an eye opener that I could normally run very fast and I couldn't. When I became a consultant, I would tend to go and see patients in the emergency department, and I would think, well, okay, well, this person will get better in whatever 3, 4, 5, 6 days, and that would be the EDD. Although in those days we did not have the term EDD, but yes, likely to go home in 5 days or whatever. And of course, 5 weeks later, I would still see that patient lingering in some of the medically fit for discharge type wards. And then I started to question myself whether it was my clinical acumen or my treatment plan, or whether something else that was not right. And over a period of time, I realized it wasn't the clinical acumen, but it was the lack of activity in the hospital, which actually prolonged that stay and caused often irreversible harm, but which is very clearly preventable. And so those are two short personal experiences over a period of years that led to my personal interest in deconditioning, and subsequently the National Deconditioning Prevention and Awareness Campaign in 2016, followed by the reconditioning games in 21, 22, and so on. So, but that's about that. But let me just give you what's happening elsewhere. So we've linked in with Sir Muir Gray's active partnership network. I went to speak at their forum, and I've invited them to come and speak at this forum at some point in time. We still need to confirm the dates, but it's likely to be June. So Sir Muir Gray's forum is very similar to this forum, but they are very geographically based. So every patch will have some kind of a network of active partnerships, and they do all kind of promotions and network meetings and so on in their patches. And once a year they have a national conference, which is what it was last month in London. We have also linked with Sarah Price. Sarah Price is the new National Clinical Director for Public Health, and she has got an interest in activity and exercise. So I'm going to meet with her personally next month sometime, and I'll keep you posted of what's happening. We've also got a very active engagement now with Sports England, and I met with the I met with Natasha, who is the head of the faculty of sports medicine. And she is very keen to come to this forum and talk about her own experiences and things as to what we can do, etc., together. On another news, the British Geriatric Society is working on a program called What Good Rehabilitation Looks Like. So I'll keep you posted about this. Just a second, Joe, just a second, 2 minutes, yeah. So I'll keep you posted about what the BGS comes up with, what good rehabilitation looks like. And in NHS England, we are thinking of working on a program called Community Productivity Improvement Program, whatever that comes up with the final title, I don't know, but there is some work happening around this. And Kate Tantam, who's just been here, and it's so inspirational, and I can't look. I really want to see her in person. And Kate, we will probably meet next week. So Kate has been a one-woman army doing a lot of stuff around ICU rehabilitation and so on. So and you've heard Kate on this forum before. Finally, the medals tally is still open, although we are not publicizing it publicly at the moment or on Twitter. But if your teams are doing something different, something good, which I'm sure you are, then please do keep on submitting for the medals as you were doing before. So that's it from me. I'll of course keep you posted either on the Twitter link or on the WhatsApp group or at the next monthly forum here next month, whenever that is. So, and thank you for that. And Kate, you have got your hand up.
Sorry, I was just going to say it's going to be great to be able to welcome parliamentarians and peers next week to the House of Commons meeting, where Amit will be representing the Reconditioning the Nation team, where we're going to hopefully have a room full of 60 healthcare professionals from across the UK, speaking to parliamentarians and peers about the importance of rehabilitation, looking at our work with Petition for Rehab. Nationally, to try and get a lead for rehabilitation and a rehabilitation strategy within every organisation and every ICB. So just to let everyone know that we are still working really hard on that, and Amit is going to be representing the BGS, but also representing all of us to be able to really push that forward. So that's super exciting. But I hope that when we next meet, we'll be able to say that we've fixed it, haven't we, Amit? That's the plan.
Absolutely.
We'll have Victoria in the room and we will have fixed it, but we'll try.
And thank you, Kate, for organizing all this. You've been amazing.
Brilliant work, thank you. And to think, you also do your day job as well, Amit, as well. I mean, it's what's happening next week is fantastic and well overdue, isn't it? But something we're all very passionate about. So it's really good to hear the updates and what's happening nationally. Thank you, and well done, Kate, for continuing to be tenacious in this topic area. Has anybody got anything else that they would like to add, or a question or anything at all? Amit's just done a plug there for the deconditioning WhatsApp group. The link to join that is on the invite to this meeting. Amit also mentioned the meeting next month, which is on the Monday, the 20th of May. It'd be great to see some of you. These meetings aren't mandatory, they're just very informal about coming together, how we can share good practice and kind of move some of the work forward. We're already talking about audits. There's a lot of chat on the national WhatsApp group about measuring of deconditioning and harm whilst patients are in hospital, different tools that share different organisations and systems are using to do that, and there are some kind of leading organisations that are really taking this to the next step. So we would try and get some speakers, and some of you, whatever you're doing in your organisation, please do contact us, because we want to share it and promote it, because everything you're doing is for the well-being of the patients and getting the staff, and more importantly, we've heard in numerous occasions today, getting family members and visitors involved in some of the rehab and deconditioning prevention, because that gives them a purpose as well when they're visiting. So unless anybody's got anything else that they would like to raise, I'll call the meeting to a close, and you can have a few minutes back of your day. Okay, I'll post all the links and things in the recording on here and in the links to the futures page, but all the links are in the invite. So great to see you all, and see you on the 20th of May.
And thank you to Amy and Imogen and Zoe. Well done. Thank you very much. And lovely to see you all.
Thank you very much.
Bye-bye for now.
Take care. Bye.